Hi, everyone. Thank you so much for joining our panel. So we're welcoming back our speakers. So Dr. Lordick, Abigail, Melissa, and Aki, and also Teresa. She's going to also sit on this panel. Teresa, as she's mentioned, she has a little bit of knowledge about genetics, being a Lynch syndrome survivor. So welcome to everyone. Now, just looking at the question tally, the questions that are coming in, they're just overwhelming us right now. So I do apologize to all the viewers. We're not going to be able to get through all of the questions today. What we did was just before our presentation, we did get some questions from the audience, which we will ask our panelists. And our panelists here are a good mix of both medical professionals as well as patient survivors and caregivers. So when we ask these questions, they might be a little bit specific to either a healthcare professional or a patient, but we really want to hear from everyone here because this is a way for us to learn from each other. So it's not just the medical voice, it's not just the patient voice, it's you guys learning from each other. So with that, if we can just get the list of questions, please. Perfect. So the first question comes from Jeff, and he's a survivor from New York. This is a bit of a specific question related to COVID. So do total gastrectomy patients have any increased risk associated with COVID-19? And anyone can jump in from the panel, by the way.
Perhaps Dr. Lordick?
I would say it's not one of the typical comorbidities that has been identified as a risk factor to have a severe course from COVID-19. I would answer in general, no. It's not a major risk factor.
Okay. And anyone can jump in, by the way, to answer these questions. The next question is actually a video here. It's Kristen, and she's a patient from Leipzig, Germany. And I'm going to just play her video. It's a video question.
Hello, my name is Kristen. This question is for Dr. Florian Lordick. I'm getting my treatments in University Clinic of Leipzig. I'm currently on my 4th line for FERI, and I was advised to look into clinical trials, but I'm not sure what I should be paying attention to while looking at these trials. My goal is to treat this disease as aggressively as possible. Yeah, thank you.
So although this question was directed towards Dr. Florian, I think the bigger issue here is clinical trials. We hear a lot of patients being diagnosed at later stages. And there's a big challenge to really understanding what is a clinical trial, when are they appropriate, how to navigate clinical trials. There's also an issue with accessing these clinical trials. So it might be available in the US or in Germany, but it might not be accessible to patients, let's say in Toronto or California. So anyone here on the panel, if you could please answer that question. Thank you. And don't be shy.
Maybe I'm starting first, and thank you for this video message from one of the patients treated at my center. I would say clinical trials are always indicated. There is no line of treatment or no condition where a clinical trial could not help to improve our knowledge of gastric cancer. There are surgical trials, there are perioperative trials, there are trials about nutrition, but of course there are many trials about new medical treatments also. There is always some hope associated with trials, especially when it comes to new technologies or new treatments. There are also limitations. One needs to meet inclusion criteria. The trial must be open. Sometimes it's difficult to see that a trial is open in Los Angeles or Toronto or New York, but didn't come to Germany. We in my center, we are very trial oriented. We always try to offer our patients all the options which are out there, but we are not open for all the trials that exist in the world for a variety of reasons.
And Abigail, I know you have had some discussion about clinical trials, and you talked a little bit about it during your talk. How did you feel as a patient navigating that very complicated, in my opinion, system?
Yeah, I actually before originally I was referred to Princess Margaret, and my hopes was to get into the trial in there for immunotherapy. I did all the testing, was a good candidate, but I was not told that my hemoglobin levels had to be at a certain level. So when I actually went into the trial, my levels weren't where it needed to be. And had I known before, maybe I would have done something to be able to have all the prerequisites. But at that moment, I needed to start treatment right away because my cancer was quite aggressive. So I opted to start with chemotherapy. Now, I wasn't able to get into the trial that I needed. And even now, I'm looking into see if there's any way that I can get immunotherapy through any trials. And I haven't had the luck as of yet to be able to find that help. But what I ended up doing is having the same treatment, but paying it from my own pocket, unfortunately. So it really has come to doing more research and being able to see within my perimeters if there is any trials available. And there are some great resources. You have to do a lot of research. And also you have to have a really good open communication with your own oncologist to be able to find the solution that works for you. And if that oncologist is not giving you the results that you need, you look for more options. You look for second opinions.
Okay, so I think that's a very important point to highlight from the patient perspective. So we do hear this a lot, is that patients are not informed about clinical trials, and a lot of times they do have to advocate for themselves. So that's a learning point, I think, for our health professionals here in the audience as well. What about you, Aki? So I know that you were a huge advocate for your father. A lot of clinical trials are being done in the United States, unlike Canada. What was your experience? Is the States any better at talking about clinical trials, offering clinical trials?
So I'm very lucky that my dad's first line treatment worked. I didn't actually have to push to get him into a clinical trial, which is great news for me. But in the States, I think part of the problem that we have with clinical trial is that there's a washout period. It's about finding the right team of doctors at the right time, at the right place, right? So if you need to start treatment right away, that you might not be eligible for a clinical trial. There's a washout period. There's certain testings, especially for certain markers. So yeah, we also have a huge problem with clinical trials and getting that available to patients immediately at diagnosis.
Okay, thank you so much. And we have a lot of questions about early diagnosis of stomach cancer. So Natalia, she wants to know, how do we diagnose stomach cancer at earlier stages? And then another question from Kim is, what are some of the symptoms of stomach cancer? For example, how did Abigail know something was wrong with her? And this is, again, open to anyone here.
I may want to speak from my own point, but for me specifically, and from the people that I've met, specifically young population, being diagnosed is definitely been a challenge. I mentioned on my talk that usually we are brushed off as young and healthy. And one of the main things that I have to say is that you know your body. You have to listen to your body. I went into my own family doctor trying to find answers for kind of just bloating that I was getting. And ultimately, the symptom that led me to go to the ER because I wasn't getting the answers was me having to go to the washroom from what I thought was a UTI that wasn't going away. So I had to advocate because I knew something was wrong. And when I was told that I had cancer, it didn't come to a surprise to me. I knew there was something off, and I'm happy and I'm glad that I went to the ER when I did to be able to find the solution. or the treatment that I needed to get better. Like I mentioned, there is not a lot of protocols specifically in America as a preventative method. Some of the things that I had specifically was gas. For example, drinking a beer would make me very bloated. In the middle of the night, I would feel some sort of pain on my stomach. And the one that really made me concerned was the tumor that I started growing from my ovary that started pushing my I guess urinary tracts, and I was in need of going to the washroom very often.
Thank you so much for sharing that. Teresa, she is an early gastric cancer survivor. What were your symptoms when you were going through this?
So yes, I just wanted to quickly jump in so that others can speak as well. But I was pretty much what you would consider asymptomatic. I mean, I'd always had digestive issues, but that was right from university. And so I did in fact have an ulcer, but what brought me to being diagnosed is because of the family history. So my dad had passed away of colon cancer at 65. He was diagnosed at 61. And my mother had also passed away of a brain tumor. So we were just running some regular testing because I was kind of in that age frame, 10 years or 15 years prior to the age when my father was diagnosed. And so my stomach cancer was actually found at an early stage, but it was also found by luck because I think we were actually looking for colon cancer. Not that that's much better, but I was asymptomatic. I mean, I wasn't losing weight. I had none of those symptoms, but my family history sort of pushed my doctors. And also, because I had had a very, very early stage cancer, like 9 years prior, which was bladder cancer, they just wanted to make sure. So, but I didn't have any symptoms whatsoever.
Okay, so it sounds like with Abby, she had a lot of frank symptoms. With Teresa, it was a bit of luck. Aki, what was your father's experience like?
The main symptom for my dad was the gastric bleeding, but before that, the little symptoms was he had H. pylori. He had heartburn. He was losing weight. He went from 171 pounds to 150 pounds in that short amount of time. So, but I often hear from a lot of people, I mean, early diagnosis is a really, really, really tough one, or interception of stomach cancer is a really tough one. I'm actually working with Stand Up to Cancer. They just formed an early detection gastric cancer dream team. So we're trying to figure out how to prevent stomach cancer from happening to certain people and how to diagnose it at a much, much earlier stage where the curative path is a much easier goal to attain.
Amazing. I think that's going to be some very fascinating research. Dr. Lordick, Melissa, any tips on early detection? I mean, I know that's a very difficult topic to just get into for this panel discussion, but anything that you guys can mention about early detection? What are the symptoms that you're noticing? And actually, another question here was, why are different symptoms associated with gastric cancer? So if you can speak on any of that.
I mean, what I see in... Yeah, sorry.
No, go ahead.
Melissa, please.
Oh, I was just going to say, as most of you said, early gastric cancer doesn't present with very many symptoms. So by the time you see symptoms, it's often a bit of a later stage. The symptoms would be the feeling of bloating, weight loss, vomiting with or without blood, issues swallowing sometimes. So those would be some of the symptoms of the later onset. I would say, depending on the type of stomach cancer, so the intestinal type of stomach cancer can sometimes present with an ulcer or changes in the cells called metaplasia. And so when you do an upper scope, they can sometimes look for these features and biopsy an ulcer and sometimes find early cancer then. Diffuse gastric cancer is a little harder to find because it's under the lining of the stomach. So that would be a much harder thing, which is why we recommend surgery. I will say one area of research that people might be interested in is cell-free DNA, which is markers or DNA that the tumors shed that run around your bloodstream. And a lot of research is going into taking blood samples from people to see if they can identify DNA from a tumor through a blood test and then trace it back to the primary cancer. And this might be an exceptional area of research for people with hereditary syndromes because they're at such high risk to get cancer that taking their blood samples on a regular basis might be able to help us learn more about how cancers develop. So I think in England, actually, they're about to trial it. And we don't know how early the cancers are when they see this DNA or how effective it is, but that is on the horizon to watch out for.
Okay, and Dr. Lordick, did you have something to add there?
Yeah, two things I wanted to add. Many of my patients, really many, when we go back to their personal history, we can identify a point where they realized already something, feeling of fullness, difficulties to swallow. But until the diagnosis was made, there is often a delay of 3 months, 4 months, sometimes even 6 months. And this is dramatic. Therefore, the word awareness is very important. And I think that is something where you are doing a great job, that you increase the awareness for stomach cancer. And also the availability, of course, of endoscopy must be increased. It's clear that not the whole population can undergo an endoscopy every year. This is not in our all interest. But if there are symptoms, the way to the doctor and to the endoscopist should be shorter. And the second thing has been already mentioned in part by Melissa. The only chance if we get a better outcome of gastric cancer is if we diagnose early. And I'm pretty sure that our tools of prevention will look different in some years from here, with more involvement of genetic signatures, of risks that people know that they have, for instance, a risk, a predisposition for this or that cancer. With the use of artificial intelligence that integrates family history, things which have to do with their lifestyle, which tells them you have a risk for this or that. And so this is also about research. We need to go into more research for preventive measures. And so that's something where you also can work to stimulate good trials that go into prevention strategies.
Absolutely.
Katie, can I mention one more thing?
Yeah,
Also,
absolutely.
anemia, which is when your blood count is low, can sometimes be a sign of bleeding internally. And so I would just urge people, don't forget to get your physicals. Don't forget to keep up with your general health because, you know, maybe not everyone can get an endoscopy, but people can get blood tests through their doctor at their annual physical. And if they detect anemia, they might then recommend doing endoscopy, which maybe will be able to find things. So just to keep up with your general health, which we're all neglecting a little bit during our COVID times.
Right, and that's a very good point. So it is COVID time, so do be cautious about going to the hospital, but also make sure to advocate for yourself. If you're noticing a change in symptoms, make sure you get those things checked out, COVID or not. You are your biggest advocate. So thank you for that. Now we are getting an overwhelming amount of questions, and I do apologize. I'm just looking at my phone here to look at these questions. But these questions are from several individuals related to genetic testing. So some of them are very specific, and we will try to get to your questions later on, perhaps offline. And Melissa did do that very wonderful summary slide of who should get tested, what are the indications for testing, and this might be a good point to bring up. If you think that you should get testing, genetic testing, speak to your medical team, and they'll discuss the pros and cons of that for you. There is one question from Lena from Toronto. She was wondering, she says, I had genetic testing done through MedCan here in Toronto. No mutations have been found to show hereditary causes to my stomach cancer. They said that they can continue to screen that sample for future new mutations that may be discovered. Is this sufficient, or do you recommend that I redo genetic testing in 5 years?
So usually, MedCan is a private clinic, so they might have different protocols than typical clinics, but generally nobody goes back and automatically rescreens the blood sample. So we do store blood samples. We can use them to rescreen people, but usually rely on the patients to contact us and ask us for retesting, and that's how we do it. So if it's been 5 years, it's a good idea to call the clinic if you haven't been and say, can you just reevaluate my genetic test and see. And the other thing is, not all genetic tests are built the same way. So you want to make sure that the genes that are associated with hereditary stomach cancer are on that panel. And sometimes people will write me or other experts in the area to say, can you just take a look at my panel, make sure everything that you would have tested for is included. Although I suspect MedCan does a nice panel, but that's what I would suggest.
Okay. Thank you so much. We'll go back to our slide questions. So just the questions that people submitted before the conference. So this is from Catherine. She's a caregiver. And she says, I have 2 first-degree relatives die from stomach cancer, my brother 42 and father 53. There's little information in the way of screening. What specific screening would you recommend for me, 46, and how often? My deceased brother has 4 children. What surveillance is recommended for them, and at what age should this be initiated? Now, again, this is a very specific question, so we would love to hear from the panelists about their experience with genetic testing. Melissa, if you want to answer that specific question, that's perfectly fine. Also, another thing to mention here is screening with children when you know genetics are involved, so that might be something that you want to discuss as well.
So it's a little hard to answer a question like that because, as I said, not all stomach cancer is the same. So we'd want to know, what kind of stomach cancer was it? Was it intestinal type? Was it diffuse type? And you would need, or we generally get people to allow us to go back to the hospitals where they keep records for a few decades, and we can try and confirm the kind of cancer people had, because if it's a diffuse kind, you don't screen in the same way as an intestinal. So I would say the first thing is to be assessed by a genetic clinic to find out what kind of cancer it is. And then we may recommend endoscopy. We often recommend being tested for H. pylori to ensure you don't have that. You can eradicate that bacteria if you do have it. In other words, take antibiotics to get rid of it and reduce that risk. So there are things that we can do. It is hard to know how often you should screen. In other words, is going every year what you recommend? Is going every 5 years too late? And it is a little bit difficult there are no exact guidelines in Canada for people who don't have a known hereditary condition on how often to screen, unfortunately. So there are better protocols in places like Japan, where the stomach cancer is much more common, but there aren't in Ontario. So I would say get assessed by a genetic clinic, and they might be able to help you with your screening and potentially discuss genetic testing for you, because you might be eligible on your own.
Okay. And Teresa, I know that you've had a lot of ups and downs with Lynch syndrome. Is there anything that you can say specific to genetic testing, hereditary causes of gastric cancer, cancer in general, that might be helpful to our viewers here today?
Sure. I can speak just a little bit about my experience. So I wasn't tested until after my gastric cancer diagnosis. And the reason I was tested was I was young, so I was 45 at the time when the diagnosis came through. And also there was a long history of cancer on both sides of my family. And also I had also had another cancer when I was 36. So I was kind of like, I don't know, perhaps the best candidate to get genetically tested. And Both my surgical oncologist recommended it and my medical oncologist recommended it. And so I was very lucky that my healthcare team was great and knowledgeable about genetics, because oftentimes not everybody is. So I went through the process, and back then, which was about 9 years ago, I did the blood test while I was going through treatment, but it took about 3 months to get the results back. And I think that was because they had to test my tumor as well as everything else. And I tested positive. So for me, it has always been a double-edged sword. So I finally got the answer as to why I'd been hit with cancer twice. And to be perfectly honest, I'm now battling a third one, but that's a story for another time. And so it gave me the answers that I was looking for, because otherwise I was like, twice, like, what's going on here? But it also it actually put a big burden on me, because I had to now let my family know. So both my parents were deceased by the time. So I had to let my brother know and my sister know to get tested. And I had to reach out to all my first line cousins and like aunts that were still alive, or uncles that were still alive, and basically explain what Lynch syndrome was, because very few people knew about it. And it was interesting because part of me felt guilty. And I know it's kind of a crazy thing to say, but when you're calling people and you're calling like your cousins and you're saying, hi, how are you? I was just diagnosed, and now I have to tell you that you have to get tested because we have, there's this genetic mutation that we have. So long story short, everyone was very supportive. I think most of my cousins did get tested. And most of my first line cousins were negative. But we did find out that the mutation comes from my mother's side. And a lot of my second line cousins have been affected by Lynch. So we are kind of one of those families that are, I don't know, a great big family tree of people with all types of Lynch cancers. And I do thank some of my second line cousins, because they've been really supportive, because they knew prior to it, before it was called Lynch, it was called and Melissa, you can repeat the name because I can never get it right.
It is HMPCC.
Oh, that's the short form.
Hereditary non-polyposis colorectal cancer syndrome.
There you go.
That's a mouthful.
Yeah.
Okay, I'm just being conscious of time. Would anyone else like to comment perhaps on the genetics and their experience with genetics, hereditary cancers? Aki, Abigail, Dr. Florian. Oh, Abby, we can't hear you.
Yeah.
Sorry. I could probably speak from my own personal experience. My mom was actually diagnosed with breast cancer at 19 years old. So we thought maybe there was some sort of mutation in my DNA because of that. Melissa did talk about the link between breast cancer and gastric cancer. However, when I went to get my genetic results, it turned out that I don't have any sort of mutations. So there is definitely a gap in that, but it was relieving knowing, not for myself, but for my family, to get the tested done, because I do have younger siblings, I have older siblings, and a handful of families that are young, and if there was anything that we could do to prevent it or get tested done for them, I was gonna do it. And doing the genetic testing was a great relief, and result to see that yes, in fact, it is not a mutation, but also that left me wondering with, well, what happened, right?
Thank you for sharing, Abby. If I can get the slide presentation up again. So we unfortunately only have time for one more question. There's a lot of questions coming in about late advanced stage gastric cancer. So one of the questions that we have here is from a patient in Johnson City, Tennessee. And it asks if surgery for stomach cancer removal isn't possible, what chemo options are there? So just speaking about what options are available for advanced disease in stomach cancer. And that's a big one. So oh, Teresa's speaking. We can't hear you. Oh, there you go.
Okay. Perhaps Dr. Lordick can answer that. I wouldn't want to venture to answer.
In principle, it's not a short answer, but maybe to try to make it short, we definitely know that chemotherapy can help in these circumstances. There are some conditions where we try to do chemotherapy and make the cancer operable. I don't know if the person who asked that was asking for that particular aspect. It's absolutely important also in under these circumstances that the treatment is given in a center that has interaction, discussion on the case, also during the course of the disease, competent multidisciplinary tumor board. And even if surgery will not be possible, we know that chemotherapy can help to keep symptoms low, can help to maintain people alive. And so these options should really be tried and given in a competent way. There is not only one chemotherapy, there are lines of chemotherapy, there are different options. Just before our patient from Leipzig said it's now a fourth line of treatment. This is also something we cannot do in all patients, but it is more and more done. And I would also like to mention one important thing. Immunotherapy is now coming into play. Abigail mentioned that she's receiving immunotherapy in combination with chemotherapy. This will probably play a bigger role in the near future because there are positive study data out now. And also genetic testing is playing an increasing role. And we are testing more and more patients for mutations in their tumor to look for specific individualized treatment. This is still at the beginning in gastric cancer, but it's getting more and more. And from time to time, we are finding options also in the context of clinical trials. All this needs to be done by experts, by gastric cancer expert medical oncologists.
Thank you
I just
so
wanted
much.
to add, sorry, Katie, just to add that as far as immunotherapy, the testing of the tumors can sometimes really help determine if you would be have a better response for immunotherapy. So I mentioned the MSI test. There's also something called a PD-L1 receptor that they can look at, and these are tumors that may respond better to immunotherapy. So, and then there's also, of course, the genetic profile of the tumor there, which is evolving. But to see somatically what genetic mutations are in the cancer, I mentioned the precision medicine. That's exactly what it's for, to see is there a way to target this cancer that is inoperable, to try and shrink it to the point where perhaps one day it will be operable, and that's the goal.
So I just wanted to add two things to Dr. Lordick's point, and also to something that Abigail mentioned. As you guys know, we run support groups, and something that we hear from patients often is for advanced stage cancer, sometimes cancer can be treated like a chronic condition. So, perhaps the patient wasn't able to get surgery right away. So then they tried some chemotherapy that shrunk their tumor, and then they were able to get surgery. Or they tried one type of chemotherapy that reduced their tumor burden, helped with some of their symptoms, and then they tried another one. So we hear a lot of patients with advanced disease look at cancer as kind of something that's chronic. So rather than curing it, perhaps getting more treatment, trying different clinical trials to improve their quality of life and increase their survival as well. And then the other thing that to mention, so Abigail mentioned that we want to make sure that our patients advocate for themselves. So perhaps if you're not comfortable with your original healthcare team, if you don't like the options that they're giving you, you're always allowed to ask for a second opinion, a third opinion. As Dr. Lordick mentioned, there are tumor boards discussing options for each patient. So make sure you're advocating for yourself, make sure your caregivers are advocating for you, because there are a lot of options for advanced disease. And with that, I realize we're over time. And again, I'm so sorry that we weren't able to get to everyone's questions today. Like I said, what we're going to do is after today's discussion, we're going to ask our speakers to see if they can answer some of these questions and perhaps make them available on our social media and our website. I do want to say a big, big thank you to everyone for joining us. It seems like we have a worldwide audience and worldwide speakers. You guys are just amazing, and we genuinely couldn't do something like this without you guys. So thank you so much. What we're going to do now is we're going to take a 10 to 15 minute break as we get the afternoon panel mic'd up. But again, thank you so much to our speakers and everyone that's joining us today.
Yes, thank you, everyone.